Types of atrioventricular reentrant tachycardia, AVRT. 4 types of AVRT are described. 1. Orthodromic slow-fast AVRT, anterograde conduction is slow, traveling in the normal, ortho, conduction pathway, AV node his Purkinje system, while retrograde conduction is fast, traveling in the bypass tract. 2. Orthodromic slow AVRT, similar to the above type, but conduction in the bypass tract is also slow. 3. Antidromic fast slow AVRT, anterograde conduction is fast traveling in the bypass tract, while retrograde conduction is slow traveling in the his Purkinje system AV node. 4. Bypass tract AVRT, a very rare type, in which both anterograde and retrograde conduction travels in bypass tracts. Orthodromic types are narrow complex tachycardias, NCT, unless there is aberration or pre-existing bundle branch block. While antidromic AVRT and bypass tract AVRT are wide complex tachycardias, WCT. Prevalence. Orthodromic slow-fast AVRT, around 95% of cases. Antidromic AVRT, around 5%. Orthodromic slow AVRT, very rare. Bypass tract AVRT, very rare. Orthodromic slow-fast AVRT. In most patients with AVRT, the refractory period of the bypass tract exceeds that of the normal conduction system. Therefore, a premature atrial contraction may block at the bypass tract, and conduct anterograde in the normal pathway, ortho, then through the ventricular tissue, entering the bypass tract in the retrograde direction, and re-entering the atrium, to establish a reentrant tachycardia referred to as orthodromic AVRT. Rate, 140 to 240 per minute, but may occasionally be faster or slower. The delta wave is absent and QRS is normalized during orthodromic AVRT, because the normal conduction system is used for ventricular activation, and the bypass tract only for return to the atria. Since atrial activation is retrograde, P waves have reversed direction, and usually occur on the ST segment, with an RP interval of at least 50 ms, and usually greater than 100 ms, but still RP is shorter than PR and VA is shorter than AV, that is short RP, short VA tachycardia. Rarely the P wave is minute and not seen. Although it is a general rule that narrow complex tachycardia with absent P waves is almost always typical AVNRT. But it could be anything, because P waves may be very small to see in other arrhythmias. Differentiation between typical AVNRT and orthodromic AVRT is discussed earlier. Orthodromic slow AVRT. Orthodromic slow AVRT is rare and usually presents clinically as persistent junctional reciprocating tachycardia, PJRT. The bypass tract is usually inferoseptal, thus the P waves are usually deeply inverted in inferior leads. Antidromic AVRT. In this form of AVRT, anterograde conduction occurs down the bypass tract, followed by retrograde invasion of the AV node, to establish an antidromic tachycardia, which is one type of pre-excited tachycardias. The QRS complex is wide, and may be difficult to distinguish from ventricular tachycardia, VT. Pre-excited tachycardias include 1. Antidromic AVRT. 2. Bypass tract AVRT. 3. Pre-excited supraventricular tachyarrhythmia, due to the presence of a bystander bypass tract, that is not part of the tachycardia circuit, but only shares in its anterograde conduction, including pre-excited atrial fibrillation, pre-excited atrial flutter, pre-excited atrial tachycardia, pre-excited AVNRT. In orthodromic AVRT, there is anterograde conduction in the AV node, and retrograde conduction in the bypass tract, BT. In antidromic AVRT, there is anterograde conduction in the bypass tract, BT, and retrograde conduction in the AV node. Bypass tract AVRT conducts anterograde in the AV node, and in one of the bypass tracts, BT, then retrograde in the other bypass tract. Pre-excited atrial tachycardia, atrial fibrillation, and atrial flutter, conduct anterograde in both the AV node, and the bypass tract, BT, resulting in fusion QRS, as occurs in sinus rhythm. Pre-excited AVNRT also conducts anterograde in both the AV node, and the bypass tract, BT, resulting in fusion QRS, as occurs in sinus rhythm. AVRT in concealed WPW syndrome. In concealed WPW syndrome, the bypass tract cannot conduct in the anterograde direction. Consequently, only orthodromic AVRT can occur, utilizing the bypass tract for retrograde conduction. Thank you.